Hello. Just to give you a little bit of background, I've been working with opioid-addicted pregnant women for 10 years, and we have the ability to do the withdrawal for the neonatal abstinence babies, and we also are recently become a health home for opiate women with Gateway in the state. So that's my experience for talking about this. Now, as we talked about statistics, and some of the other doctors talked about statistics, it's very difficult to gather the statistics because if you see here, in the past few years, the increase in neonatal abstinence syndrome, which is what NAS stands for, has gone from 1.2 to 5.8 babies per 1,000 hospital births. This is a statistic of about 0.5%. I looked at my hospital, which only delivers 600 babies a year, and we have 4.6%. So that shows you right there, the statistics can be skewed. Then I spoke with my husband who does Suboxone, and in the past 5 years or 3 years, there's become more of an acceptance of admitting that you're an opioid addict and dealing with it. But 5 years ago, we were delivering babies who were on Subutex, who we didn't know were on Subutex. And if neonatal abstinence takes 5 days to show its face, and a baby goes home in 3 days, a baby goes home and you never realize that the mother was on opiates. So again, our statistic collection can be very difficult to find. Anyway, that leads into how are we going to screen these women? The American College of Obstetricians and Gynecologists is now recommending that we use universal screening, meaning that every woman who comes in pregnant be screened for opioids in her first visit and throughout the pregnancy if there's suspicion and at delivery. The United States Preventive Task Force said, nah, there's not enough evidence to do that. But of course we follow the ACOG, the American College of Obstetrician guidelines, and we're screening everyone. And it's good because then somebody comes in and you're not saying, I'm picking you out because I'm suspicious of you. You're saying we screen everyone, and we use it to be helpful. We don't use it to call children and youth and take your baby away. We use it to get you in a program and help you get through your pregnancy. And the one thing you have with pregnant women is it's kind of a window of opportunity where somebody wants to do something. Nobody wants to be a drug addict. Nobody wants to hurt their baby, but because it's a disease, they get stuck in it. So we're doing the screening, and it is amazing what you find. Another thing is some of the, there was a county in Florida where they were screening 10 times more African American women than anybody else. But the statistics did not show that there were 10 times more abuse. It's through education, it's through economic level, it's through all races. You can't discriminate any one group. So now we've identified somebody's got opioids in their urine, and now you can start the conversation. What are we gonna do to get you through this pregnancy and get this baby to be the best that it can be? Well, we've got the medically assisted treatment, which we've already been told is definitely the treatment of choice, and it is in pregnancy as well. Methadone and buprenorphine do not cause teratogenicity in babies. They cause neonatal abstinence syndrome. You may have a little more premature labor, but withdrawal of a heroin addict is far worse for that pregnancy than using a medically assisted program. So it started out that methadone was the treatment of choice, but just within the past few months, it really has turned around that we probably are going to move to buprenorphine as the treatment of choice, because in the babies, there's 89% less use of morphine to help get them off the drugs, and it is also 43% less hospitalization time in the babies that are withdrawing from buprenorphine rather than withdrawing from methadone. Now, it doesn't mean methadone's not bad, and I would be interested to hear some of the panel's opinions. I have used buprenorphine. We now have a methadone clinic in town, and I am now learning, using that in people who need it. But who really needs the methadone? I've had very good luck with buprenorphine, and thus the better findings that we have. And you can also start buprenorphine in your office. You don't have to go every day. But some people need that every day, and those are the people you probably need to have on methadone. Now, in pregnancy, you don't want to stop someone from methadone and go over to buprenorphine. It's not really recommended. But there are some studies that are now talking about withdrawing pregnant women from their opiates, which had been contraindicated before. They are finding some success with that, but in reality, there's a 50% relapse rate, and there are very few people who are going to successfully withdraw in pregnancy, because especially pregnancy is an exceedingly stressful time. And during times of stress, it's not so easy to withdraw. So methadone, buprenorphine, you can use assisted withdrawal, but you've got to have really heavy counseling coordinated with that if you're going to get any success. Now, prenatal care. I did mention that there's really not a lot of teratogenicity. There's not a whole lot of special prenatal care you've got to give. You might want to watch for growth of the baby. You want to make sure that they're in a good program coordinating counseling with Subutex. We use Subutex, which is buprenorphine alone. Suboxone is buprenorphine plus naloxone, which makes it almost impossible to shoot and get high. But we use Subutex purely to decrease the amount of drugs that we give to a baby. You can use Suboxone, but we frown on it and try to go with just the Subutex. So you're using the Subutex, you're in a counseling program, you're checking for Hep C, which is a big thing, and it can be transmitted to the baby. You're checking for HIV, all of your STDs, which are higher in your substance use disorder group and can be transmitted to babies. So you want to be coordinating that care. The other thing that some of the doctors were talking about is that this group of women, and it's been amazing to me in my 10 years to see how abused so many of these women have been. I have women that have been trafficked in Hanover, Pennsylvania. You don't think of that. Women who have been in the sex trade as a way to get their drugs. Women who have been tremendously abused by opiate addicted or alcoholic partners. And so you've got these women that you've got to find to put them in a safe situation. You know, where are they living? Are they safe? How do they get there? Most of them don't have a license. Most of them don't have a vehicle. So you've got to work on how to get people places. You've got the diagnosis, you've got the mental illness, and now you've got the drugs that are for mental illness, the SSRIs. You can have withdrawal in a baby from SSRIs, but you want to use them in pregnancy because it's far better for the mother's mental health to be treated than not to be treated. And there's a lot of misconception about that as well. So you've got all these other issues: housing, abuse, transportation, and then you're talking about all these treatment programs, as like Dr. Gordon was showing, the beautiful pathways we have to treatment. But think about it. You're a mom, you've got 3 kids, you have no transportation, you've got a job, you've got to get to your physical therapy, you've got to get to your psychiatric views, you've got to get to your counseling session, you've got to get to your OB doctor. Come on, man, how many of us even go to the doctor? I mean, you've got to think about it as we develop these programs for people. How do we make programs that people can really follow? And so those are issues that we have to deal with. Peripartum management, you come into labor. How do we handle your labor pain? You may have an epidural, don't use fentanyl in it. You may have opioids after your C-section. Do you need to give more? Some of the literature says you have to give more. I don't find that. I keep them on their Subutex or their methadone, and I add the opiate to it, and they seem to do all right. And as they go home, I try to see if we can maybe use their Subutex and ibuprofen for pain and not give them an opiate. And sometimes that works, and sometimes that doesn't work. You can use the Subutex a little higher dose for the pain. What we did find in some recent articles, the Green Journal, which is from the American College of Obstetricians and Gynecologists, recently, just last month, had an article that obstetricians were giving out 40 Percocet for a postpartum C-section. People were using maybe 15 or 20. So there you've got 20 million across the country extra Percocet on the shelves for people to divert. So we've got to get physicians aware that we've got to give fewer amounts of drugs. If people need it, they can come in, you can check them out, and you can give them more for acute pain. But many people, most people, do not need 40 Percocets postpartum. So that's another thing that was come out. And then we talked about that. Whoops. Okay. NAS, one of our doctors was a pediatrician. NAS, neonatal abstinence syndrome. Babies that are born on methadone, buprenorphine, SSRI, cigarettes, alcohol, benzos, you name it, can have withdrawal. Not all babies will. Some babies will withdraw sooner, some babies will withdraw later. We do find that babies on buprenorphine do require less morphine to assist their withdrawal, and they do have less withdrawal, but they may not show this withdrawal till 5 days. So we mandate that a baby stay for at least 5 days before we let it go to make sure it's not going to go through withdrawal. And then some babies who are in withdrawal have to do morphine to help them withdraw. Newer studies are saying that buprenorphine is actually going to be better for withdrawal for babies, but it's not yet FDA approved. So I'm pushing my pediatricians to get there if we can, because again, it's going to be less of a risk for people. We need to have universal screening, which we talked about, and we need to keep the mom and baby together. CYS coming in and taking the baby away is not the answer. We're even working on programs in York County Prison to let moms keep babies with them. Now that's going to be a long time coming because of the structural facility space and things like that. But these are the ideas that we're working on, because moms and babies staying together make the mom have the incentive to stay clean, be clean. Breastfeeding, you can breastfeed with methadone, you can breastfeed with SRIs, you can breastfeed with buprenorphine. All of these things you can breastfeed with, and it supports that dyad. And we don't want to take moms and babies away. Recently had a mom deliver who had cocaine in her urine. She was on methadone. She was denying it. We got her to admit that she'd used. And what I told her is, all right, we're going to tell CYS, but if you're in the programs, you're doing the programs, you're coming to things, they're not going to take your baby away. If you screw up, they'll take your baby away. But at least there's the real incentive, and you don't have that in just your routine patient. You really got that incentive with a mom and a baby. So our future needs are, we need more research to know what's optimal screening, what's optimal treatment and care, what are we doing postpartum, how do we prevent the depression, what do we do for the birth control that we need to get them on, you know, how do we get them into homes where they're safe when they're living in shelters. Neonatally, we have to have a better scoring system so that everybody's scoring the babies correctly. You know, some people that are subconsciously against buprenorphine or methadone might overscore babies. Other people might underscore babies. We need a real uniform scoring system. We need what's going to be the best way to help babies in withdrawal. Do we have to use drugs? Can we use swaddling? Can we use different techniques? We need to know what is the long-term effect of medically assisted treatment. Literature suggesting that 5 years of methadone does not really cause a problem, but we don't have a lot of good statistics on things. And we need to understand the genetics, because addiction is also a genetically related disease. And these babies, how do we prevent them from becoming addicts in the future? And how do we work on this system where there's so much mental illness from so much abuse that has created this drug seeking and this drug using to treat this mental pain? We need as a society to find ways to make our families more supportive.